I thank the Manipal team for inviting me to a talk on Rivaroxaban, looking beyond stroke and DVT prevention in their annual update of 2020. It is a great endeavor, in fact, and I feel honored to be a participant speaker in this session. So let us see what was Rivaroxaban. If you see the timeline of development of anticoagulants, you will see that all the anticoagulants have been started since 1940, and as the anticoagulants are being used, so we see that it was in 2008 that dabigatran and Rivaroxaban came into being. So from 1940 onwards to 2020, we have been having a host of anticoagulants which are coming into play. Now, what is the role of Rivaroxaban? If you see, we all know that Rivaroxaban has got a good role in preventing strokes, in preventing peripheral artery disease, and also pulmonembolism, and we have used it a lot. As we cross to 2020 and we have more data on Rivaroxaban, we are sure that it has got a major role to play in coronary artery disease, whether it is acute coronary syndrome or chronic coronary syndrome, and of course peripheral artery disease. So they are the newer vistas where Rivaroxaban has a role to play beyond DVT and stroke. Now, why is it that anticoagulation is required in atherothrombosis? Patients continue to be underprotected despite being on intensified antiplatelet regimens. As I see that in spite of giving good antiplatelets, they still remain underprotected. There's a high and increasing medical need in CAD and PAD patients, so the role of anticoagulation is necessary. There's urgent need to establish new or add-on treatments in high-risk groups. This is very important. Now let us see what exactly happens in all these patients. Whenever there is a thrombus, it is a composition of fibrin or fibrinogen with or without platelets. It may be a platelets with fibrinogen or fibrin itself with the red. So here for the platelets, we give the antiplatelets, but for the fibrin or the fibrinogen, we have to start thinking of giving, that is, anticoagulants. Now, this is what we call as targeting the dual pathway inhibition. We usually think of giving antiplatelet. That is one way we try to inhibit aggregated active platelets, and then we have to start thinking of giving anticoagulants so that we start taking care of the fibrin and in the long run take care of the clot that takes place. Now, if you go further, we see, if you have to see beyond stroke and DVT, as I had already mentioned, that is a potential use in coronary artery disease, in acute coronary syndromes and chronic syndromes, in peripheral artery disease, post-angioplasty, and polyvascular disease. There's a 4 indications which have come up in 2020 where we have a role of using Rivaroxaban. If you try to see the spectrum of trials that have gone in 2009 to 2019, we'll see there were 3 trials, the Atlas TME 46, ACS TME 46, and the Atlas ACS TME 51, which included 15,000 patients, and the Gemini ACS, there are the 3 trials that were done in ACS cases. Then in chronic patients, the COMPASS trial was done in chronic coronary artery disease and peripheral artery disease, and the Voyager trial was done in acute peripheral artery disease. Of course, there's another trial of the Commander heart failure, which was done in heart failure patients. Now, if we see, first let us come to acute coronary syndrome when the patient presents with acute symptoms, and is there a role of Rivaroxaban? Let us try to see. Now, if you see, these post-ACS patients, in spite of the guideline recommended therapy, there is almost a 15% cardiovascular death, MI, stroke as the patient passes through almost 3 years. So how do we prevent this 15% incidence of events that do occur? Now, if you try to see, if Rivaroxaban, the Atlas ACS TB 51 trial in which Rivaroxaban was given a vascular dose, you have seen there was a decrease in cardiovascular death, there was a decrease in both CV death, MI, stroke, and decrease in all-cause death. So this was very important that adding a vascular dose of Rivaroxaban does do a lot of benefit in these patients. Now, Rivaroxaban reduced the major adverse cardiac events, as you see, that compared to placebo. But of course, one has to agree that there was some increase in the amount of bleeding that occurred, both intracranial hemorrhage, but fatal bleeding was not very significant. So at the cost of decreasing the reduced major adverse cardiac events, the bleedings were higher. So is there a role of Rivaroxaban in ACS? Yes, we know that DAPT is the recommended guidelines, and Rivaroxaban vascular dose plus DAPT is an alternative. And there has been seen a significant reduction in cardiovascular death and all-cause mortality in secondary prevention of ACS in acute phase. And the most important thing is that we have to select the right patient. And who is the right patient? Those with increased ischemic risk, who have elevated factors, those without increased bleeding risk. This is very important, because those who are at high bleeding risk, we cannot give them because they have more chances of bleeding, and use it caution, especially the creatinine clearance is less than 30. Now, to bring a balance, what you see in the green is what is a patient without bleeding risk, that is, they have no history of stroke or TIA, no current or recurrent condition of major bleed, BMI 30, creatinine clearance and hemoglobin 12.5. These are the patients which can be weighed and individually analyzed, and then you can see whether they can be put on Rivaroxaban 2.5 milligram. Now let's come to the second indication of chronic coronary syndromes and peripheral artery disease. These are the second two indications that we used. And then came the COMPASS trial, which was published on October 5th, 2017 in the New GM. Very important to note that the antibody investigations were stopped 1 year ahead of expectations in February 2017 due to the overwhelming efficacy of Rivaroxaban 2.5 milligram BD with aspirin. So here is evidence that if you give Rivaroxaban 2.5 milligram BD with aspirin, the results are good. 3 arms are taken, one with Rivaroxaban with aspirin, Rivaroxaban, plain Rivaroxaban, and aspirin alone. And what was seen was that the patients that were selected were a very high-risk patients. They all had previous MI, multiple vessel disease, multivessel PCI undergone, multivessel CABG, and most importantly, they had multiple vascular risk factors that was included as the CAD patients. And all the PAD patients had previous revascularization, previous limb or foot amputation, or the ankle index was less than 0.9, that's significant peripheral artery disease, previous carotid revascularization, or coronary artery disease with a low ABI. This was the criteria that was chosen. And what was seen as most interesting was whenever Rivaroxaban was added, the 2 arms definitely did better. Now, I see the vascular dose of Rivaroxaban when added to aspirin, it not only decreased the major adverse cardiac events, it decreased the cardiovascular death, MI, stroke, and of course all-cause mortality. So here is the reason, as per the COMPASS study, that we have every reason to add a vascular dose of Rivaroxaban to a single antiplatelet. Now, most importantly, to see that when you see the major events, major adverse cardiac events, it was significantly decreased whether the patient was a diabetic or was not a diabetic. So irrespective of the risk factor of diabetes in present, if you add this vascular dose, it was beneficial, but at the cost of the fact that there was some amount of major bleeding that was seen. Now, if we try to see the efficacy, the major bleeding at the end of 2 years were almost comparable. If you see the forest diagram over here, it does not cross to this side. It favors almost, it has got a neutral value. So it is safe to add Rivaroxaban, a very low dose, 2.5 milligram twice daily, to aspirin in patients of chronic coronary syndrome and peripheral artery disease. Now, even if there was heart failure, it was seen if no heart failure is there, there was a risk in reduction, and if the patient had heart failure, it was seen that compared to plain aspirin, if you add Rivaroxaban, there was definitely the cumulative hazard was much less. So heart failure patients also do improve to some extent, but there have been trials which have shown that in the long run it is not much beneficial. Now, a very important thing to debate on is that the absolute benefit of Rivaroxaban vascular dose plus aspirin is highest in the high-risk patient groups. So more high-risk the patient is, that is for the full COMPASS population, or more than 2 vascular beds, or history of heart failure, or eGFR less than 60, or history of diabetes, all these patients did well. And if on top of lipid lowering, blood pressure lowering, AC inhibitor, you add the vascular dose of Rivaroxaban with aspirin, it was seen that almost a 23% decrease in all-cause death and 26% decrease in major adverse cardiac events was there. So this translates to the fact that there was a 44% relative risk reduction in any type of stroke. Now, if so, the question comes that should do pathway inhibition replace DAPT to prevent MES and chronic CAD. The evidence that we have from comparing all these trials is that the Compass definitely decreased MES much better than the Capri, Charisma, Pegasus, or whether 90 or 60 with aspirin, cardiovascular death, stroke, MI, and with a bleeding risk which is much lesser than the Pegasus study compared to what the Compass showed. So we have reasons over here that a dual platelet inhibition is necessary in these patients. Now, Compass is the only antithrombotic regimen significant in all possibility. Let's see about the peripheral artery disease. It in fact decreased stroke significantly, and also the major adverse, that is the limb events, were also decreased significantly when Rivaroxaban 2.5 was added to aspirin 100 milligram BD. So if you try to summarize, whatever the subset, this diabetes, sedentary impairment, heart failure, polyvascular component, they all did well when a vascular dose of Rivaroxaban was added to aspirin. So what are the clinicians of Compass? If it is prudent to add a dual pathway mechanism inhibition, bleeding risks were almost similar, excepting for a little higher risk in the Rivaroxaban arm, and showed that it was superior to aspirin alone, and the net clinical benefit was also definitely better as seen in the sub-analysis. Now, then came the guidelines, European guidelines, where it was clearly gave a 2A indication that adding a second antithrombotic drug to aspirin for long-term secondary prevention should be patients with high risk of ischemic events without high-risk bleed. Very important, any high-risk patient should be put on a second antithrombotic drug, and that should be Rivaroxaban. And if you try to see the Atlas and the Compass, if you try to compare them, it is seen that cardiovascular death and all-cause death was definitely reduced in the arms on whom Rivaroxaban was put. So it shows that whether it is an acute event or a chronic event, definitely Rivaroxaban does well. Now, to be summarized, we can say that it is prudent that in addition to DPT, one should add Rivaroxaban and gradually change over to a single antiplatelet. And even if the patient has multivessel disease, Rivaroxaban addition in chronic coronary syndromes is prudent. Now, after this, let us come to the Voyager pad, which is an acute peripheral artery disease where it was used. There are two arms, the Rivaroxaban with the aspirin arm versus the aspirin arm, and there are 6,564 patients. And it was very important to note that the Compass patients had less risk factors so far as PAD was concerned compared to the Voyager arm. The Voyager arm were all symptomatic, all undergoing revascularization, had carotid vascular disease with or PAD, had 100% revascularization, or were allowed for up to 6 months of clopidogrel, and the major adverse cardiac events and acute limb ischemia or major amputations were all considered. These were a much higher risk population than the Compass arm. And then based on the Voyager, it was the 2019 European Society Vascular Medicine Guidelines had clearly gave a 2A indication that the combined therapy of aspirin with Rivaroxaban should be considered PAD patients without a high risk of bleeding or other contraindications. Even the 2019, the Global Vascular Guidelines for Management of CATI also considered this to be a class 2 indication. Now let us take the third subset of post-PCI. Post-PCI, we can have two subsets, either atrial fibrillation post-PCI or just plain post-PCI. The atrial fibrillation post-PCI was evaluated in the Pioneer AF-PCI study, in which there are 3 arms after PCI. The patients who had AF, there is quite a substantial number of patients who have AF post-PCI or have AF, and we do a PCI in them. And it was seen Rivaroxaban arm versus the DAPT arm versus vitamin K arm. And all these patients had paroxysmal persistent permanent non-valvular AF and have undergone PCI with a stent placement, and the INR was less than 2.5 at randomization. So what was seen was that in both the arms, whether they were put on only Rivaroxaban with single antiplatelets or Rivaroxaban with a DAPT versus vitamin K antigen plus DAPT, they did well compared to a DAPT alone. So here comes the information that adding these strategies of Rivaroxaban does do well, but it is important to know that the efficacy was almost similar whether you give a VKA or a DAPT with Rivaroxaban. But we have to be clear about what is the role post-PCI, that is after PCI, is there a role? Let's compare DAPT versus Pegasus versus Compass. If you take all the three studies, DAPT had clopidogrel or prasugrel plus aspirin, Pegasus had ticagrelor with aspirin, Compass had Rivaroxaban with aspirin. And I here show that that is the ACA, which was the adverse cardiac events, was much less in the Compass arm compared to the other arms. So this shows that possibly we have a favorable benefit ratio, risk ratio when you add Rivaroxaban. Now let us compare to Themis, which came later on. It has shown, if you see the both compared Compass PCI with Themis PCI, it is clear that in Compass PCI, the use of a dual pathway inhibition compared with aspirin alone consistently showed a reduction in all-cause death and severe mortality, of course, with a little risk, high risk of bleeding. So we lastly come to polyvascular disease. We know that the Charisma study has shown that if we add a dual platelet or a split, it definitely has a significant role, and there's a modest space benefit without significant reduction in mortality, MI, and ischemic stroke. But if it is continued to more than 30 months also, we see there's no significant reduction in cardiovascular deaths or stroke on prolongation of DAPT for 30 months. But what happens if you add Rivaroxaban? If you add Rivaroxaban, it was seen that if Rivaroxaban was added to aspirin or alone, there was almost a 49% reduction in the ischemic and the uncertain stroke, which was very significant. Similarly, ischemic stroke was statistically very significantly decreased. So here we have another post-PCI. If you want to decrease the amount of strokes also, there is possibly a role of just giving Rivaroxaban with aspirin. And now here you see that the Compass carotid clearly showed that the numbers which were much lower in the Rivaroxaban arm compared to aspirin arm. So this comes to, that is the fact that we have to look beyond stroke and DVT prevention while using Rivaroxaban. There is a role to use in acute coronary syndrome, chronic coronary syndrome, peripheral artery disease, post-PCI, whether the patient has atrial fibrillation or does not have atrial fibrillation, and polyvascular disease where you want to decrease the incidence of CVS. But it is, in practice, it has not yet picked up this much, but we have much evidence. And there are two studies which are like, the Rivaroxaban did not show superiority. One was the Commander heart failure study, because we are discussing over the recent advances. The Commander heart failure study did not show a good benefit of Rivaroxaban in this subset of patients. And Rivaroxaban was also used post-TAVI patients and was shown to have, the Rivaroxaban had a higher rate of major disabling or life-threatening bleeding versus the antiplatelet group, so it is not recommended. So it's not recommended that your patients who undergo TAVI should be put on Rivaroxaban in contrast to antiplatelet. So lastly, to conclude, Rivaroxaban possibly is jumping from use in stroke, DVT, pulmonary embolism to newer vistas of CAD for ACS and CCS, PAD, post-PCI, polyvascular disease, and possibly this thing, that is this NOAC, to see that we have a larger spectrum to use and give more benefit to our patients. Thank you very much for the patient hearing. I'd be